Hi. First and foremost, thank you for taking time to watch this presentation. I am Tamika Patterson, and I will be talking about splitting schizo hairs between schizophrenia, schizophreniform, and schizoaffective disorder.
When talking about schizophrenia, we should realize that it is very diverse in character and contact. There are lots of criteria that need to be met according to the DSM 5 TR for someone to be diagnosed with schizophrenia. So, criteria A has multiple symptoms that should last for at least a month, such as delusions, to the extent where someone's really unable to help you justify that your delusions are incorrect. Then there's hallucinations. These hallucinations happen outside of the sleep state and are most commonly seen in audible or visual aspects, meaning that you hear or see something that is not there. Disorganized speech, which is also known as disorganized thinking or disorganized formal thought disorder, meaning that you would have what we call word salad, or you would answer people in a conversation that only makes sense to you in a way. There's also disorganized behavior, which are random outbursts of agitation or laughter with no given reason, and sometimes with a state of catatonia, meaning that you express no emotion of facial expression and sometimes are in your own world and not coherent with the world around you. Catatonia can be like that waxy complexion as well. Then you have the negative symptom, meaning you are not responding to the environment in a socially acceptable way, such as you have decreased facial expressions, complete lack of eye contact, and sometimes failure to initiate any type of speech or movement when talked to or around others. So that's criteria A. We also have criteria B, which is impairment in one or more major aspects of functioning. Criteria C is some signs of disturbance persist for at least 6 months. Criteria D is that we have ruled out schizoaffective, bipolar, or depressive symptoms. And criteria E is there is no reason someone is hallucinating or having delusions because they are under the influence of any substance, that being drugs or alcohol or medications given to them by a doctor. These can be found on page 113 and 114 of your DSM 5 TR. Schizophrenia is not something that is episodic. It is a constant disorder that has ongoing symptoms. When someone with schizophrenia has delusions, they will be mood neutral. So those can vary whether they are bizarre or non-bizarre, but mood neutral means that they weren't caused by like a mood disorder. If one has delusions that are produced by moods such as mania or depression, it would be best to look at schizoaffective disorder.
So what is that? What is schizoaffective disorder? It's a combination of schizophrenia and a mood disorder. When going about diagnosing one with schizoaffective disorder, we would want to specify if it's schizoaffective disorder with bipolar type or with depressive type. So schizoaffective can best be described by the ABCs of psychology. So we have schizo, meaning that it affects the cognitive part of your brain, and that is how we think. And then we have the affective part of the disorder, which comes from the affect part of the ABCs of psychology, meaning that it controls the thoughts and feelings. If criteria A is met in full for schizoaffective disorder, then we would go on to look at schizophrenia. Criterion B for this disorder states that delusions or hallucinations should last upwards to 2 or more weeks in the absence of mood disorder. In the video that we watched by Dr. Tracy Marks, What is Schizoaffective Disorder? Is it worse than bipolar disorder? She explains that those who suffer from bipolar disorder have states of depression and then a gap of no symptoms, and then depression, gap of no symptoms, and then may go into like a manic season. Or with schizoaffective, we see those gaps of no symptoms are actually filled with states of psychosis, whether it be delusions, hallucinations, or a combination of both. We have that constant state of psychosis, along with whether it be bipolar or depression. Also, something that Dr. Tracy Marks explained in her video was those who suffer with schizophrenic symptoms will always need to be on a neuroleptic medication versus those suffering with just bipolar or depressive diagnoses. They can be on a mixture of anticonvulsants, neuroleptics, antidepressants. It really does vary depending on the doctor, depending on the symptoms and the history. This is why diagnosing schizoaffective disorder just by a medication list can be tricky. In schizophreniform disorder, some of the key factors that differentiate this disorder with the rest is the lack of impairment in social or occupational functioning, and then the specifiers listed in the DSM-5-TR. This meaning that there is no criteria for impairment of social or occupational functioning, which is something that is present in schizophrenia and sometimes in schizoaffective disorder. Going on with the specifiers in the DSM-5-TR is whether they are prognostic features or not, and that is something that I'll talk about later on in this presentation. So what are the differences between schizophrenia, schizoaffective, and schizophreniform? Schizophrenia symptoms in criteria A would have to persist for at least a month, but can go upwards to 6 months. Now, those active symptoms can, as I said, show for only a month worth, but usually it's a little bit longer, and that's kind of how we differentiate. Again, the psychosis of this disorder is not episodic, but more of a continual disorder. So those who suffer from schizophrenia tend to have a very poor history and functioning within the community. They struggle both in academia and in their workplace. In schizoaffective disorder, there is no lack of mood, such as mentioned previously in schizophrenia with the catatonia. Sometimes we can have that waxy complexion, no eye contact, no facial emotions whatsoever. This does not happen in schizoaffective. Matter of fact, it is a combination of schizophrenia and a mood disorder. Again, we would specify whether that was of a bipolar type or depressive type, which we can find those specifiers on page 121 of the DSM-5-TR. With schizophreniform, the symptoms of criteria A show for at least a month or up to 6 months, like schizophrenia, but unlike schizophrenia, the specifiers listed for schizophreniform is whether someone has a good prognostic feature or if they lack prognostic features. So those are the two specifiers that you can choose from. These prognostic features are as follows. So there's onset of prominent psychotic symptoms within 4 weeks of the first noticeable change in unusual behavior or functioning, confusion or perplexity, good premorbid social and occupational functioning, and absence of blunted or flat affect. The key is that two of these prognostic features have to be met, and those can be found on page 111 of your DSM-5 TRs. If they are not met, then you would list it as schizophreniform with no prognostic features. So why is this information important to know? Why should we even know about specifiers or modifiers? Well, as you can probably tell, there is some overlap between all three of the diagnoses, such as time of symptoms that are persistent, criteria, etc. So it's important to bring awareness to the specifiers for each individual diagnosis so someone is diagnosed correctly and can get the help that they need. Thank you for sticking around with me and watching my video. I hope my explanations were in depth and provided further understanding. I look forward to learning more about schizophrenia and its other diagnoses on the schizo spectrum, as we should say. Thank you, and God bless.